Along with a detailed history, a properly executed physical examination is vital to correctly assessing a patient with a spine problem. This video will detail the essential physical examination techniques for the spine. Physical examination for the following regions will be demonstrated: the cervical spine, the thoracic spine, and the lumbar spine. Patient inspection starts when the patient enters the room. Observe the patient's attitude. Pay particular attention to see if the patient is protecting any part of the body. Observe how the patient carries the head. Watch the patient and note any deformities or abnormalities. For palpation, it is best to examine the patient supine, since the muscles overlying the deeper prominences are relaxed. For palpation, we examine two aspects. First, the anterior aspect, beginning with the hyoid bone, which overlies the third cervical vertebra. Cup your hand around the anterior portion of the neck. We ask the patient to swallow, and the movement will allow us to palpate the hyoid bone. Moving inferiorly in the midline, we can palpate the thyroid cartilage by identifying the superior notch. The top portion is known as Adam's apple, which marks the C4 vertebra. Immediately inferior to the lower border of the thyroid cartilage is the first cricoid ring that overlies the C6 vertebra. Laterally to the first cricoid ring, you can palpate the carotid tubercle, which is the anterior tubercle of the C6 vertebral process. For the posterior aspect of the cervical area, stand behind the patient's head and cup hands under the head so that the fingers meet at the midline. From here, you can palpate the occiput, which is the posterior portion of the skull, then the inion, which is a dome-shaped bump on the midline of the occipital region, which also marks the center of the superior nuchal line. Lateral from the inion, you can palpate the superior nuchal line, which is a small transverse ridge extending to both sides of the inion. We can also palpate the spinous process, the most prominent of which is the spinous process of the C7, which we can readily palpate on full flexion of the neck. In the cervical spine, it is important to note that 50% of flexion and extension occurs between the occiput and the C1, and the other 50% is evenly distributed among other cervical vertebrae. For lateral rotation, C1 and C2 are responsible for 50%, while the remaining 50% are evenly distributed among other cervical vertebrae. And these are the range of motion for each movement. The first motion we will test is that of flexion. The primary flexor of the cervical spine are the sternocleidomastoid muscles. To examine resisted neck flexion, stand to the side of the patient. Place one hand on the patient's forehead and the other on the posterior neck. Direct the patient to flex the neck by retracting the chin and pushing the forehead into your hand. Resist the motion. Next is extension. The primary extensors of the cervical spine are the splenius, semispinalis capitis, and the trapezius. To test resisted extension of the neck, stand at the patient's side and place the palm of your hand on the patient's chest. Place the elbow of your free arm on the posterior thoracic spine and that hand on the back of the head. Instruct the patient to push back with the head onto your hand. Resist the movement with an equal and opposite force. For lateral rotation, the primary rotators are again the sternocleidomastoid. To test motion of the left lateral rotation, stabilize the side of the right shoulder with your hand and place your other hand on the left mandible. Instruct the patient to rotate his head against your palm. Do this for the opposite side as well. Lastly, we also test for side bending. The primary side benders are the scalenus muscles. To test resisted side bending to the right, stand behind and to the right of the patient. Place your right elbow on the patient's right shoulder and your palm on the patient's head, just above the ear. With the other hand, grasp the patient's left shoulder. Instruct the patient to side bend the neck to the right and resist the motion. Repeat the test for side bending to the left. This second part is based on the fact that pathology in the cervical spine is based on the brachial plexus. The following diagnostic tests will help determine whether there is a relationship between upper extremity neurologic problems and a primary source in the neck. The sensory dermatomes of C2, C3, and C4 give sensation to the back of the skull and the neck. Because these roots have no significant myotome, the diagnosis of upper cervical radiculopathy relies often on these dermatomal abnormalities, which must be tested specifically with a pinwheel. The lower cervical dermatomes demonstrate a well-defined dermatomal map displayed in the figures. The brachial plexus comes from the roots of the C5, C6, C7, C8, and T1 nerves. We test these dermatomes with light touch and pinprick sensation. Using a cotton pledget with a sharp tip, we can easily test both of these sensations with one tool. The cotton tip is for testing light touch, while the sharp end is for pinprick. The following are the areas where we can test these levels. Always test both the right and left dermatomes. We interpret these sensations using a percentage as reported by the patient. It is also important that we ask the patient to close their eyes as to increase the accuracy of our exam. The motor examination involves testing the different muscle groups in the upper extremity. These muscle groups are called myotomes, and they correspond to a certain level in the cervical spine. The motor strength per myotome level is graded from 0 to 5. The following are the criteria for giving each grade. The reflexes are also graded to determine if the lesion is upper or lower motor neuron in origin. There are 5 grades, 0 being absent reflexes to a grade of +4, which represents hyperreflexia with clonus. C5 is best tested by the deltoid muscle. The deltoid is innervated almost entirely by C5, hence we test for shoulder abduction. To perform shoulder abduction, have the patient stand or sit with the arms resting alongside the body. To test the left shoulder, stand to the left of the patient and place your left hand on the patient's distal upper arm. Place your right hand on the hip or shoulder to stabilize the patient. Instruct the patient to push the arm into abduction and resist the motion. Repeat the test on the right shoulder. Record your findings using the muscle grading score described earlier. Testing the biceps reflex also corresponds to the C5. Have the patient sit with the forearm flexed and relaxed at an angle of 90 degrees. The patient's forearm rests over your forearm. Grasp the patient's elbow with your hand, placing your thumb over the biceps tendon. Strike your thumb over the tendon with a reflex hammer, watching for contraction of the biceps muscle. Motor testing of the C6 nerve root is difficult because the testable muscles of C6 are also partially innervated by other nerve roots. Because the wrist extensors have a larger C6 contribution, we test these muscles. To test for wrist extension, grasp the patient's elbow at the proximal forearm. Place your free hand on the dorsal aspect of the patient's hand. Instruct the patient to extend the wrist against resistance. The brachioradialis reflex also corresponds to C6. The position is the same as when testing the biceps reflex. Grab the patient's arm with your right hand over the triceps. Using the reflex hammer, strike the brachioradialis tendon at the musculotendinous junction in the mid portion of the radius to elicit a jerk. Motor function of C7 is tested by the strength of the triceps and the flexors of the wrist. For this level, we test elbow extension and wrist flexion. To test elbow extension, place one hand on the elbow and grasp the patient's wrist with the other hand. The hand on the elbow fixes the arm during the exam. With the elbow fully flexed, instruct the patient to extend the arm against resistance. To test wrist flexion, instruct the patient to make a fist and grasp the hand from the palmar side. Hold the underside of the patient's wrist with the other hand for support. Instruct the patient to flex the wrist while you attempt to pull it into extension. To test the triceps reflex, grasp the inner aspect of the arm. Instruct the patient to fully relax the arm. To elicit a jerk, tap the triceps tendon with the reflex hammer just proximal to the olecranon, where the tendon crosses the olecranon fossa. Motor function of C8 is best tested by finger flexion and thumb adduction. To test finger flexion, instruct the patient to make a fist. Grasp and secure the arm and wrist of the patient with your free hand. Curl your fingers under the patient's fingers and try to extend them. To test thumb adduction, the patient's palm faces upward. Stabilize the wrist by holding the ulnar side of the wrist and hand. Take hold of the thumb in an abducted position and instruct the patient to adduct the thumb against resistance. Motor function of T1 is best tested by finger abduction and adduction. To test finger adduction, instruct the patient to abduct the little finger. Grasp the patient's wrist for support with the index finger of your hand and hook the patient's abducted little finger. Further instruct the patient to adduct the little finger against resistance. To test finger abduction, hold the patient's wrist for support. Instruct the patient to extend and spread the fingers. Attempt to adduct the fingers in pairs. First, adduct the index and middle fingers, then the middle and ring fingers, and finally, the ring and little fingers. And now we move on to the thoracic spine. Inspection for the thoracic spine is the same as in the cervical spine. It starts when the patient enters the room. Observe the patient's attitude, and we note any deformity or other abnormalities of the thoracic spine. Palpation of the thoracic spine generally requires us to palpate the spinous processes. Place the thumb of each hand on the spinous processes and begin to palpate in a caudal direction. Note any misalignments, curvature, lumps, pain, tenderness, and/or swelling. And now we test for the range of motion. These are the range of motion for each possible movement for the thoracic spine. To test forward bending, ask the patient to bend over and touch the toes without bending the knees. Take note of flexibility, fluidity, and restriction of movement. To examine thoracic extension, palpate the spinous processes of T12 and L1. Instruct the patient to fully extend the spine by bending backward. Place one hand on the back of the patient to detect the point at which the spinal extension moves into the lumbar vertebra. Thoracic trunk rotation occurs with the patient seated with arms crossed and hands resting on the opposite shoulders. A wedge or block is placed under the patient's buttock on the side being tested. The elevation of the buttock will lock the lumbar spine in contralateral side bending and ipsilateral rotation. Instruct the patient to rotate as far as possible toward the side where the block was placed. Note any pain or limitations in movement. To test active side bending, instruct the patient to cross the arms, resting the hands on the opposite shoulders. Ask the patient to side bend to either side. The crossing point of the arms will form an imaginary axis of rotation. Note any pain or limitations in movement. The neurologic evaluation for the thoracic spine involves testing the sensory distribution of the spinal nerves since there are no testable myotomes for this segment. Significant overlap exists in sensory innervation of the thoracic region. Any particular area of skin is innervated by three different nerve roots. Three major landmarks for sensory levels exist in the thoracic region. These are the nipple line, which represents T4, the umbilicus, which represents T10, and the inguinal region, which represents the lower thoracic and upper lumbar levels. Testing the sensory function of the thoracic spine is the same as that of the cervical spine. We test the light touch and pinprick sensation in the dermatome levels of both sides. To test the abdominal reflexes, instruct the patient to undress above the waist and lie supine on the examination table totally relaxed. Individually stroke each quadrant of the abdomen lightly. The umbilicus normally migrates toward the quadrant being stroked. Diminished movement may indicate an upper motor neuron lesion. An asymmetric loss of the reflex may indicate a lower motor neuron lesion. Next, have the patient do a sit-up. If the umbilicus moves upward during the sit-up, it implies a lesion at T10 or below. If downward motion occurs, the potential lesion is at T10 or above. Asymmetric movement here is the Beavor's sign. Thoracic spine should naturally have some degree of forward curvature called kyphosis. An excessive forward curvature of the thoracic spine results in a deformity known as hyperkyphosis. This deformity can significantly impact a patient's physical function and quality of life. To further evaluate thoracic kyphosis, ask the patient to bend forward at the waist until their chest is parallel to the ground. Once the patient is in the correct position, look for rounding of the thoracic spine. Assessing the flexibility of the thoracic kyphosis will help determine the intervention needed to correct the forward curvature. This can be done by having the patient lie in a prone position on an exam table. The lumbar spine is assessed in the same manner as the other segments. To begin inspection, check the back for areas of redness and unusual skin markings. Skin markings such as the following indicate different conditions of the spine. Lipomata and port wine marks can indicate spina bifida. Patch of hair on the back may be a sign of diastematomyelia, and skin tags or pedunculated tumors may indicate neurofibromatosis. From the side view, a gentle lumbar lordotic curve is normal. In the lumbar region, palpation should include not only the lumbar spine but also the iliac crest, sacrum, sacroiliac joints, ischial tuberosities, proximal hamstring, and greater trochanteric areas, as indicated, to assess for the possibility of contributing problems from these regions. Trochanteric pain may mimic pain from a spine etiology. In assessing range of motion of the lumbar spine, it is important to know the normal range of motion of this segment. Flexion in the lumbar spine involves relaxation of the anterior longitudinal ligament and stretching of the supraspinal and interspinal ligaments, the ligamentum flavum, and the posterior longitudinal ligament. To test flexion, instruct the patient to bend as far forward as he can with his knees straight and to try to touch his toes. Interesting to note that there is no reversal of the normal lumbar lordosis during flexion, and that, at most, the low back merely flattens out. To examine lumbar extension, place a hand on the patient's lower back over the posterior superior iliac spine. Instruct the patient to fully extend the spine by bending backward and using your hand as a fulcrum for his motion. Take note of the fluidity and range of lumbar extension. Lateral bending in the lumbar spine is not a pure motion, for it must occur in conjunction with elements of spinal rotation. To test, first stabilize the iliac crest and ask the patient to lean to the left and then to the right as far as he can. Note how far he can bend to each side and compare the range of motion. To test trunk rotation, position yourself behind the patient and stabilize his pelvis by placing one hand on his iliac crest and the other on his opposite shoulder. Then turn the trunk by rotating the pelvis and shoulder posteriorly. Repeat for the opposite hip and shoulder and compare the ranges of rotation. Neurologic examination of the lumbar spine proceeds the same way as the previous segments. Testing the sensory function is essentially the same, this time focusing on the dermatomes of the lower extremity. The same sharp and blunt ends of a cotton swab may be used in testing the different dermatomes in terms of light touch and pin-prick sensation. For the lower extremity, we begin testing for the myotomes. L1, L2, and L3 are tested in combination due to a lack of specific muscle testing. The muscles commonly tested are the iliopsoas, the quadriceps, and the hip adductors. To test hip flexion, instruct the patient to sit on the edge of the examination table. Stand next to the patient and place one hand on the patient's thigh just above the knee. Place your other hand on the patient's shoulder. Ask the patient to raise the knee against resistance. This test should be repeated on the other side. For L3, we test knee extension. To test knee extension, instruct the patient to sit on the examination table with the knees bent at 90 degrees and feet hanging toward the floor. Place one hand on the patient's thigh and the other on the distal leg. Ask the patient to fully extend the leg. When the leg is fully extended, try to forcefully flex the leg. Compare the legs. For L4, we test dorsiflexion of the foot. Instruct the patient to sit on the edge of the examination table. Take hold of the patient's distal leg superior to the malleoli. Ask the patient to dorsiflex and invert the foot. With your other hand, try to force the foot into plantar flexion and eversion. For L4, we also test the patellar tendon reflex. To test the patellar tendon reflex, instruct the patient to sit on the examination table with the quadriceps completely relaxed and legs dangling. With a reflex hammer, gently strike the patellar tendon just below the patella. This should cause the quadriceps to contract and the knee to jerk. For L5, we test great toe extension. Instruct the patient to sit on the examination table and extend the leg. With one hand, take hold of the leg just proximal to the malleoli. Place the index finger or your thumb of the other hand on the interphalangeal joint of the big toe. Ask the patient to extend the toe while resistance is applied. For S1, we test plantar flexion. With the patient seated, grasp and secure the medial side of the patient's foot by fixing the calcaneus. Ask the patient to evert and plantar flex the foot. Resist the motion by using the fifth metatarsal. For S1, we can also test for the Achilles reflex. While the patient is kneeling with the foot relaxed and in dorsiflexion, strike the Achilles tendon. Plantar flexion should be observed. S2, S3, and S4 innervate the intrinsic muscles of the feet and the anal sphincter. To test the external anal sphincter, instruct the patient to undress below the waist. The patient lies on their side and brings the hips and knees into flexion. Instruct the patient to relax and insert a gloved and lubricated finger into the rectum. Ask the patient to contract the anal sphincter and feel for a change in sphincter tone. And now we move on to the special tests. To test for impingement on the sciatic nerve, we perform a straight leg raise. Instruct the patient to lie supine on the exam table. With one hand, take hold of the patient's leg just above the malleoli. Place the other hand on the thigh just above the knee. Raise the leg with the knee extended. Stop flexing the hip when pain is felt in the back and leg. A true positive straight leg raising sign is one that recreates the patient's radicular pain and not just back pain between 30 to 70 degrees of elevation. Alternatively, we can also do the well-legged straight leg raising test. We do the exact same procedure on the uninvolved leg. If he complains of back and sciatic pain on the involved side, there is further presumptive evidence of a space-occupying lesion such as herniated disc in the lumbar area. The Brudzinski's test is another procedure designed to stretch the spinal cord and reproduce pain. Ask the patient to lie supine on an examining table. Forcibly flex his head onto his chest. He may complain of pain in the cervical spine and occasionally down the legs by flexing his knees, an indication of meningeal irritation, nerve root involvement, or irritation of the dural coverings of the nerve root. The modified Sperling's maneuver is a test for cervical nerve root compression or irritation. A positive test is elicited by extending, rotating, and laterally bending the head to one side with reproduction of radicular pain into the affected ipsilateral extremity. The Hoffman test is a pathologic reflex in presence of a spinal cord compression. The patient's middle finger is held at the middle phalanx between the index and middle finger of the examiner's hand. Flick the distal phalanx at the palp with the free thumb. Flexion of the thumb and index finger indicates an upper motor neuron lesion. Babinski's sign indicates an upper motor neuron lesion or an expanding brain tumor. Run a sharp instrument across the plantar surface of the foot from the calcaneus along the lateral border to the forefoot. It is positive if the great toe extends while the other toes plantar flex and spling. Take note that in newborns, a positive Babinski is normal. Clonus also indicates an upper motor neuron lesion. Brisk dorsiflexion of the ankle causes rhythmic, oscillating, and involuntary contractions. Chaddock reflex is elicited by stimulating the dorsolateral aspect of the foot from the posterior portion of the skin just beneath the lateral malleolus anteriorly and along the external edge of the foot. Both the Chaddock and Babinski reflex lead to flexion of the big toe and fanning of the other toes when there is a dysfunction of the corticospinal tract. Now that you have learned how to properly do a physical examination of the spine, all that is left now is to apply it to an actual patient. Always remember that a thorough physical exam and an in-depth history is vital to diagnosing spine conditions.